Let's move the next section. Challenge and response in cataract surgery, case discussion. The first topic is IOL selection in RK patients, presented by Dr. Thomas Junbin Tsai. Dr. Tsai is now Vice President of Tainan Qingming Eye Clinical. Dr. Tsai, please.
Thank you. Good afternoon, ladies and gentlemen. I am Thomas Junbin Tsai. It's my honor to be here. Today's my topic is IOL selection in RK patient. It's my financial disclosure. This is a 61-year-old male patient. His previous myopia was 5 diopter in his right eye. He had received RK surgery at 26 years old and had LASIK surgery at 40 years old. He had cataract and his best correct visual acuity was 6/20 in his right eye. We can see RK cuts and LASIK flap at his cornea. This is the eye trace data of this patient. He wants to read papers and use computers. And what's your opinion about the IOL suggestion for this patient, Dr. Xu?
I'm Xu Zhenxu from Taipei Regional Hospital. So as we see the eye trace of the patient, we can see the cornea part. And we can find the triphoid, coma, and astigmatism, spherical aberration are quite high, which means that the patient is more suitable for monofocal IOL. So in such kind of patient, I would choose a monofocal IOL.
Oh, and what's your IOL suggestion to this patient, Dr. Tian?
I'm Pentai Ten from China Medical University Hospital. As we see, the severe abrasion at 6 millimeter cornea of this patient is about 1.8 micrometer. I think a spherical IOL is good choice for this patient, such as Johnson Johnson Technics IOL could correct a severe aberration of 0.2 micrometer. Although there are long astigmatic bars in the abrasion analysis of cornea, but no bow tie pattern at his topography. So toric IOL gave no benefit in this patient.
Thanks, Dr. Xu and Dr. Tian's opinion. And a spherical IOL with negative spherical aberration is suggested because it can offset of marked anterior spherical aberration in RK eyes. His optic zone is about 3 millimeter, and his pupil size is about 5.66 millimeters. Consideration of high spherical aberration, which is up to plus 1.888 micrometers, and the obvious high-order aberration of his cornea. A spherical monofocal IOL or EDOF IOL is better for this patient. Just as Dr. Halliday said, RK eyes have a multifocal cornea. You can see RK eyes have a wide range of focus. It is up to 13 diopters. This kind of multifocal cornea is the center that is relative flat for distance and the peripheral that is relative deep for near vision. Following RK, the overall lack of precision of IOL power calculation, a dynamic fluctuation in refractive power, and increase in high-order aberration preclude use of traditional multifocal IOL. High-end multifocal IOL with many diffractive rings, if you add to already multifocal cornea, it will further reduce the contrast sensitivity and increase symptoms of halo and glares. Low-end multifocal IOL or EDOF IOL are more forgiving in some RK eyes. It is case by case. Just for incision is a good candidate. More than 8 cut incision, like 16 cut, is not a good candidate for multifocal IOL. The more cuts you have, the more high order aberration you gain. If you have a larger pupil size with a normal, if you have a larger optic zone with a normal pupil size, is a good candidate. No obvious diurnal fluctuation in K reading, that means it's a relative stable cornea. Be prepared to perform IOL exchange if the result is not satisfied. This is the IOL Master 700 data of this patient. Dr. Tian, what is your opinion about the K value of this patient?
we can see there's little astigmatism noted by the after biometry. This is due to last enhancement surgery. And the RKI is an unstable cornea. In short terms, there's a diurnal fluctuation. I will perform to use the factor K. The factor K is of this patient is at 9, and that means he may have myopia refractive errors as the sunrise.
And what's your suggestion, Dr. Xu?
We can see the total K and the K, and the total K value is more flatter, which means it is not like the Euro patients as RK patients. It is a little like the patient with a LASIK, that the posterior cornea curvature is more steeper than Euro RK patients. So in such kind of patient, the patient may have hyperopia shift when they choose intraocular lens. So in such kind of patient, we will target a more myopic refraction. Thank you.
Well, just as Dr. Tian and Dr. Xu's suggestion, we should choose the factor K as a 35.77 diopter for this patient and target a more myopia result due to the factor TK as a 35.32 diopter. The problem is that over time, the progressive hyperopic shift may continue. And we have to consult the patient that no matter what we do today, these RK incisions could continue to change, as will their vision. If they don't understand this, you could have a very unhappy patient. According to the prospective evaluation of radiokeratotomy study, between 6 months and 10 years, the refractive error of 43% of eyes changes in the hyperopic duration by more than 1 diopter. The average hyperopic change is 0.06 diopter per year between 2 and 10 years. So the refractive error in the hyperopic duration continues during the entire 10 years after surgery. Smaller optic zone, like 3 mm, show more hyperopic change than eyes with 3.5 to 4 mm optic zones. In addition to the hyperopic shift, RK eyes refraction may also fluctuate throughout the day, making the intended refractive goal a moving target. To the fact that the significant proportion of RK eyes are more hyperopic, especially in the morning, the diurnal fluctuation is due to hypoxic edema or intraocular pressure change. Unlike LASIK or PRK or SMILE, RK flatten both the anterior and posterior corneal surface, but only in a small central optic zone. The effective optic zone diameter can be significantly smaller than the major zone of standard keratometry. Many keratometers measure at need of treatment zone. Therefore, standard keratometry tend to overestimate the true corneal power. It will increase the risk of hyperopic surprise. As mentioned before, RK eyes is an unstable cornea. Diurnal fluctuation could happen. It is wise to choose factor K. An IOL power calculation following RK should not be carried out using two variable third generation theoretical formula, such as SRKT, Holiday 1, and Hofer Q, because this IOL formula assumes a relation between keratometry and effective lens position. RK patients was once myopic, but now have flatter cornea. They typically have a deeper anterior chamber depth than patients with similar factor K reading who don't have any history of myopic refractive surgery. Therefore, more advanced formula would be more accurate for RK patients. For example, use Haggis or Holiday 2 or Barrett Universal 2 formula take into consideration measurement of the anterior chamber depth and determine the final effective lens position. According to the study published in 2020, if you have the refractive record before RK surgery, you can use Barrett 2K formula with history of RK. 76 of the patient's refractive result will in half diopter. If you just have the post-RK refractive result, you can use the most hyperopic refraction recorded for the patient. This was to allow for the progressive hyperopic shift that occur after RK. but also to control for any myopia shift caused by nuclear sclerosis. The partial history option was released in TrueK formula of RK 7 years ago. The partial history option can fine-tune the refractive outcome of RK eyes. If you don't have any refractive history of this patient, you can use Haig's formula or Barry TrueK formula with no history of RK. Almost 70% of the patient refractive result will in half diopter. Many surgeons prefer to select a refractive target of between -0.5 and -0.75 diopter for two reasons. First, hyperopic error are common. And second, if hyperopic shift continue, the refractive error will change toward ametropia. And now it is the decision-making time. Which idle power will you choose, Dr. Xu?
As just mentioned, because there may be a hyperopia surprise, so I will choose one target more myopic. Yeah.
And what's your opinion, Dr. Tian?
As Thomas told before, RKIs have unstable cornea. As time goes by, cornea will toward the flatter result. Progressive hyperopic shift is a serious issue. We should keep it in mind. And I think a more myopia result is a wise decision.
Thanks, Dr. Tian's smart suggestion. We should use HDD-released idle formula like Haig's formula or Barry TrueK formula with or without RK refractive history, and choose the highest idle power obtained. In this patient, I will choose the idle power as 15.5 diopter. If you target at this idle power, and you will find your target at myopia 0.3 by Barry TrueK formula, and target at 1.75 myopia result by Haig's formula, and target at 1.25 diopter by Haig's TK formula. All these results are myopic. It is a safe decision. This patient wants to use a computer and read papers. The difference between Haig's and Haig's TK is due to a steeper posterior cornea effect in this patient. This is the cataract operation video of this patient. He wants to use flex for his cataract surgery. I don't use flex to do the cornea incision in RK eyes, because I need to choose the right place to avoid the wound leakage. We should keep in mind that nearly 80 to 90% of the cornea thickness was cut during the RK surgery. Don't ever cross the RK cut incision. That will make a disaster. And see, I will make my cataract incision between the archaic incisions. It is almost possible with an 8 incisions RK, like this patient, but with 16 incisions RK, I need to go back to make a scleral tunnel. It is wise to watch the RK incisions and the zonules carefully during the cataract procedure. We must always remember that it is a myopic anatomy eye. Loose zonules and more fluctuation in anterior chamber could happen. The incision can sometimes open during the surgery, causing micro or macro perforation. So you must be prepared to close them with sutures if it happens. You can see I just put my handpiece back and forth. I don't want a laceration in my main incision. Remember, we should use your chopper smartly to grab your nucleus in front of your phaco handpiece. And the lens is divided by the flags already. And we can see I just need to use my chopper to grab the nucleus and just give little force and equal speed into half. And you can see the fluctuation is higher than other myopic eye. That is due to maybe there is micro perforation. And my IOP setting is about 14 millimeter mercury. And in the last piece, I prefer to put my chopper just below the lens and to keep my posterior capsule is safe. After the lens is removed and the cortex was removed and the polish was done, you can see the anterior capsulotomy is so round and centered by flex. An Alcon VVT IOL was inserted. It's an aspherical IOL with 1.5 diopter EDOF effect. The VVT IOL was centered and the surgery was done. This is this patient's visual outcome. You can see the visual acuity was 0.9 after cataract surgery. The refraction results show myopia 1.25 diopter. In the result, we can see the Haggis TK was most reliable. Every RK patient must understand the potential for a refractive surprise, under promise and over deliver. And thank you for your attention.
Any question from the audience? Okay, please.
Is there any hint that toric IOL can be used in RK patient? Because for this patient, it seems that this is irregular stigmatism, so it's not suitable for toric IOL. But is there any situation that we can still use toric IOL in RK patient?
Of course, there are many RK patients. We can see there are regular and irregular astigmatism. It is if you can see the bow tie pattern at your cornea surface, and you can give the patient some classes to correction. If the patient says, "I will get some improvement," then this patient may get improvement with toric IOL. Sometimes I will ask the patient to give me back their old glasses. If their old glasses have the astigmatism correction, that means this patient may be benefit from our toric IOL. Unless if we are giving correction, the patient will not say, "Oh, I feel it's worse." If it feels worse, then maybe it's not better for our toric IOL. And I think the topo is most important. And sometimes we have many optic biometry. The difference between our biometry is the meridian should be less than 15 degree, and the power should be less than 0.75 diopter. And if you have these rules, I think you can have a benefit for your toric IOL.
Dr. Tsai, thanks for the excellent presentation and very nicely performed cataract surgery in RK patients. I noticed that you insert the VVT IOL. So is there any special consideration? Because I'm quite conservative in these patients. For RK patient, I never insert the multifocal or EDOF lens. So what's your selection criteria for these patients? I have some comments for toric IOL in RK eyes. I always check not only the topography, maybe a couple of times in auto calorimetry and IOL master, and find it should be aligned with each other. My criteria is that less than 20 degree of this, misalignment, and also not exceeding maybe 1 diopter of astigmatism in their magnitude. So I want to know what's your selection criteria for this RK patient for inserting the EDOF lens.
Okay, thank you for your, thank you. We all know that my default position of RK patient is just monofocal IOL. But this patient was say he need to use a computer and he need to use to read papers. So he wants some EDOF effect. And we all know that if we give just a traditional diffractive lens multifocal IOL, it has many halos and glare to already multifocal cornea. And sometimes I will consult the patient. Here we have a new kind of non-diffractive lens EDOF IOL, like iHands or like our VVT IOL. And iHands, it does just give you just a 0.5 diopter with EDOF effect. And VVT will give you a 1.5 diopter EDOF effect. And this patient just, I think I want to try this IOL, and the result is satisfied. But before I have consulted the patient, if the result is not satisfied, we can change the IOL.